Good morning. Today we begin the public hearings into Module 7, investigating the test, trace and isolate policies of the United Kingdom Government, Scottish Government, the Welsh Government and the Northern Ireland Executive. The hearings will last for 3 weeks and 41 witnesses will be called to give oral evidence. As ever, we have a lot to get through in a short time, and so I shall keep my remarks brief. In all our modules, we start the hearings with an impact film to remind everyone why we're here. I'm very grateful to all those who've contributed to making the films. I understand how difficult it must have been for them. As with the previous impact films, this one is extremely moving, and the contributors refer to sensitive topics such as bereavement and end-of-life care. There will be those who will find it too distressing to watch. I will pause in a moment to allow those who are in the hearing room who wish to do so to leave for the length of the film, which is just over 20 minutes, and those who are following online to press mute or exit the live stream. After the film has been played, we shall reassemble, and Ms Sophie Cartwright, King's Counsel to the inquiry, will begin her opening submissions. She will set the scene, provide some background and explain the issues we should be examining in this module in more detail. Very well. If we could play the film, please.
When the pandemic hit, I was already managing complex health needs. I caught COVID 3 times and I survived intensive care twice. And now I live with long COVID. What I've learned, there are some structural injustices and structural barriers that were, I believe, exposed. There was a lack of accessible communication, and the system meant to protect us, you know, health and care and community, often operated in silos, not in unity or solidarity. And as a black person, black people were more likely to die, and disabled people were more likely to be denied care and support. The technology and being told, you know, being pinged saying you're on the vulnerable list. Nobody talked to me that I'm on the vulnerable list. For those of us living at what I call, you know, intersection, that intersectionality of being black, disabled, the odds were stacked from the start. When I had to go to a testing centre, I said, I'm a wheelchair user, is it accessible? And I was told, yeah. Went there and it wasn't, so I had to go somewhere else. And those are when I talk about communication, the lack of communication, I call that basic housekeeping. If we can't even get the basic housekeeping, that's why people go into that mistrust of what's being told. But it tells you your place and value in society. And I just think we can do better. Government must do better. We need to do some intentional actions and learning from this for me. Getting the voices of the most marginalised and asking questions around, is the system working for you? If it's not, why not? And what can we do better? We're not asking those questions. We just think a one-size-fits-all works for everyone, and it doesn't. We were an afterthought. Some of us are more valued than others. That's how it played out for me in the pandemic, and it's still playing out now, if I'm being honest.
I'm Dean, and I have several boys and speech impairment. So I'm a member of this inquiry team to remove the on my behalf.
My wife and I have physical and mental health disabilities, live in our own home, and we draw on social care in the form of employing a team of personal assistants, PAs, to support us in a wide range of daily living activities. When the chilling words, "you must stay at home," were first uttered, finding any kind of meaningful and relevant information to match our situation was almost non-existent. Should our personal assistants come to work? And if so, how many would be a safe number? Where to source the right PPE? Could we call upon family and friends if we needed? How or where could we get tested? Most of these things were eventually resolved, but by this time it all felt too late. Going for my first test was a nightmare. About 6 weeks after entering lockdown, experiencing symptoms for around 5 days, I queued alone at one of those pop-up centres, thinking it would be wrong to take a personal assistant with me. The layout of the porter cabin was far from wheelchair friendly, which only added to my anxiety. When getting to see someone in a high-vis jacket with little to no training, who simply referred me to their supervisor, I explained that I had come for a test and that I would require assistance to do the test. Their reply, after speaking to their supervisor, was that they could not possibly assist, and that another test would be sent to my home. The test arrived around 7 days later, and I received a negative result back approximately 10 days after that. Again, far too long a time period. For me, life has never really returned as what it was before. What I wish for to come out of this inquiry is for the full truth to be made clear. People in positions of power are held accountable, and that we are all better prepared in the future, and that us, the forgotten few, are no more forgotten about.
Thank you for listening.
I was working in different services at the time, and they were seen as essential. So we had to be open. We had to still do kind of work as usual. I remember picking up a whole bunch from work to test at home, like every other day, or if you noticed your nose was a bit tickly. So it became just kind of a standard act. And I remember having to do it quite often for work. And I remember as soon as someone else at work confirmed that they kind of tested positive, then you end up just kind of doing it yourself just in case you were asymptomatic. You know, you end up creating this kind of health anxiety cycle of just wanting to test to be safe, but the more you test and the more you check, the more it increases your anxiety and the distress. But in your case, it doesn't matter whether you're anxious or distressed, because you still have to go in, you still have to go to work, you still have to go do everything you're expected to anyway. I would get pinged quite often, but not in the first kind of 6 months of it. It only really started for me later on. I remember the first time being really fearful, and then I would test. But then when that kept happening and I kept randomly testing, it ended up being that, okay, I'm just getting pinged, but I think it's just a precautionary measure. So I ended up just kind of feeling fine with it. But that's me, and having the ability to kind of be reassured in that way. The rules were things that we had to follow. So we being, you know, I saw myself as part of the low socioeconomic, as an Arab myself. I didn't see myself as white, upper class, anything. I was aware that I was often treated second class by other people. So it wasn't news to me, but I think when it became a lot more apparent, and then with the Black Lives Matter movement as well happening at the same time, all of these things it really cemented that there is this divide in class. There's a divide across various of the intersections, and nothing is being done about it.
Because I have a disability, which is cerebral palsy, and we were all given letters, vulnerable letters, so we were vulnerable people, and we were treated, as far as I'm concerned, ridiculously, appallingly. I discovered through a friend, you could go to the airport to get tested. I was horrified to realise that once somebody had given me the run-through of how this would happen. How would a disabled person who, number one, maybe couldn't drive, test themselves because they were supposedly weren't tested, and go through? I heard then through the grapevine that if you were attending the hospital for some reason, there was another centre where you had to go, and you could go there, be tested, and then two or 3 days later, they'd let you know, and then you could go and get your appointment at the hospital. I thought, this is brilliant. Why can't they include people with disabilities and older people that they can go there? If they're going to call us, treat us, and tell us that we're vulnerable, respect us.
When you got tested, your phone pinged the following morning saying it was positive. But my husband's didn't. They lost his test. It didn't come back. It never pinged. Phone just didn't ping. I kept it beside me all the time. So 2-3 days later, I phoned. I was getting a bit better. And then my husband started to get worse. He started to take ill. Up in that point, he hadn't. So I thought, I'm taking him for another test. The following day, both tests came back at 5 o'clock. Within 10 minutes of each other, both were positive. And that Thursday, I phoned an ambulance 3 different times. They came each time and kept on saying, it's okay, there's nothing wrong with him. I remember kissing him and saying goodbye in the ambulance. I'll phone you tomorrow. I phoned him at 1 o'clock the following day. They said that they were going to take him for some tests. Then my phone kept on going off. And it kept on going and going. I was out and I was told I'd went into cardiac arrest. So yeah, the pinging didn't actually really work that well. I kept on getting intrusive calls from the COVID line saying, are you isolating? Are you doing this? Are you doing that? Well, what do you bloody well think I'm doing? Didn't they think that we knew that? Nothing really prepares you for it. You don't expect a death. The last thing you see is your husband in an ambulance. The shock was huge to the family. He was a man before his time, and he certainly did not deserve the death that he got. Life goes on, but it's not the same. You've just got to learn to adapt, because a lot of people, grief can be crippling. It affects every part of their life, and they've got to get the help to get through it.
My mother was admitted into hospital because she was making a cup of coffee. Because of her age as well, her hands would shake. So the kettle must have knocked the cup over, and the boiling water went down the front of us. Phoned up the out of hours, and they said it's best to let her go in. So I said, we know that COVID is really rife at the moment in the hospitals. And they said, oh, she'll be well looked after. She won't come in contact. She's classed as vulnerable. I said, we're really concerned about that part. No, she'll be fine. My mother's there crying, saying, I don't want to go, I don't want to go. If you make me go, she said, I won't be coming back. So she went into hospital. I said, no, she's not on a COVID ward, is she? And they said, no, she's had a COVID test. Her test has come back negative, so we've put her on a non-COVID ward. There was a 9-bedded bay at the bottom of the ward and a 4-bedded bay just about 2 doors away. The 9-bedded bay that was on that ward, on that same landing, was full of COVID patients. I stated a few times, is my mother with COVID patients? No. I just feel as if I let my mother down. She knew she wouldn't be coming back. And I said, don't be silly. You will be. And she said, I won't. I'll be dead. And she was.
I worked in virology laboratory. Suddenly we went from 2,000 samples a week testing to 20,000 samples a week. And our team went from 12 people to 50 through volunteers and secondments from other laboratories. We were having a continuous conveyor belt of samples running through all the machines. And we still weren't keeping up with the samples. They were still piling up. Yeah, we were inundated with samples from around the community, from other hospitals, GP surgeries, old people's homes, just everywhere.
Basically, they were looking for people with the right experience, which, because I work in cancer genomics normally, they kind of sent me across as someone that could be spared in our lab, but had the right experience on the right machines, so I could just walk in and say, yeah, I know how to do this. Because we were cancer, and a lot of what we do is monitoring of patients on treatment. Initially, our workload really dropped off, and then in the longer term, it's actually increased because of it. We're seeing more cancers that are more advanced. People are being diagnosed later because their lump was missed or they didn't get that cough checked out early enough.
Having the volunteers was incredibly helpful, but they didn't have any of the technical skills. 90% of the work fell on a core 10 to 12 people, and then the rest of the volunteers were only able to do things up to a point. Almost everyone in our laboratory caught COVID at least once, possibly twice, during it. I needed to be at work, and I needed to be doing the testing. And I knew I was already on constant exposure watch anyway. Why would I need one of those apps to ping me to tell me I've been exposed when I was under constant exposure risks? It would be as if I'd been pinged every 20 minutes, and it would have been, so I just didn't have any of it.
You can't just run on fumes forever. You have to resource services well enough when things aren't a disaster that there's capacity for growth, for failure and for difficulty. We would have had much more capacity to absorb the initial impact if we hadn't already been running understaffed and under budget.
I lost my mum to hospital-acquired COVID, and I've really, really struggled to cope since. My mum wasn't just a name and a number, she was a person, she was human, she was my mum. And I miss her so much. Until we get some answers, I feel like I can't begin to grieve properly. I put on a mask every day and try and function like a normal person, but there's just this sadness, this underlying sadness that just sits there all the time, and I struggle not to get back to any kind of normality. I feel guilty for allowing her to go into hospital. I feel guilty for leaving her there and not being able to see her. I feel guilty that I was allowed to be there and my siblings weren't. My siblings had to watch my mum pass away via a video call. I feel guilty because I'd sent Dad to the car for half an hour because the walls were closing in on him. And when he went to the car, she passed away. So I had to sit and wait for him to come back. I have constant flashbacks of all of this, which is part of my trauma. And I just don't know how to process that at the moment. I'm just not the person that I was before, and I have to live with this new person that I'm forced to be. I don't think the country or the world has realised the full impact yet of how this has affected the people that are left behind.
My mum was wheelchair bound and had been for 20 odd years, and carers came in 4 times a day. And my dad then helped in between times. One carer had to be prompted quite a few times to make sure she was wearing her PPE. So I think that's how COVID got into the house. So in December 2020, my dad took on well, but didn't have COVID symptoms. He had like an infection on his foot. And the doctor looked at it and go, yes, just to be on the safe side, maybe bring him for a COVID test. The next morning, I had got the results coming through to my phone. The test had come back positive, and immediately all my concern was for the carers were going to be coming in to see to my mum. So I tried to get hold of the domiciliary care manager, eventually got through to them, and they said, oh, don't worry. And I go, when was the last time the carers got tested? And they go, no, the carers don't get tested. He said, it's not the hospital trust policy to test the carers going into the homes of vulnerable people. So that was the start of the nightmare, realising that these carers possibly were going to pass this on. And then the next day, he was worse. So the ambulance came, I packed a bag for him thinking, okay, they'll go and check him out and he'll be home in a day or two. I seen him walking into the ambulance and he sat down. He looked at me as if, what are you doing to me? I'll never forget the look on his face, as if I had sent him to his death. And every time you would ring to find out what's happening, oh, we're too busy, ring back. It was very frustrating that you couldn't find out what was actually happening. And my mum started to not feel well. Got her test done, sent it off. And I knew it was going to be a few days until it came back. And then my mum's test came back positive. And then I went and got a test again and I was positive. Again, ambulance arrived, ambulance staff just wearing the basic PPE. So they said they put her into a room beside him. Weekends in the hospital seemed to be a real problem. Staff didn't seem to be there a lot of the time. The doctors were only on call, and it got to the stage on the Monday when the doctor rang me and he goes, "I'm sorry, but there's absolutely no hope for my dad, and we're putting him on end of life." 36 hours later, at 1:30 in the morning, I got a phone call to say they'd found him dead. There was nobody holding his hand. There was no nurse with him. He was on his own. I made all the arrangements. There was nobody to give me a hug. There was nobody to sit and chat to. I just had to do it by myself. And my poor mum, I had a video call with her to arrange a funeral. It was basically a quick service at the graveside, and that was it. Went back to my mum and dad's house after, and the phone rang, and the doctor said, "Your mum's not very well." And he says, "Can you come in?" And I thought, that's the last I'll see her. And eventually then they said I'd have to go. Palliative care had never been mentioned to me. Again, this was a weekend. There were no doctors, so I got no news. And then, as the weeks progressed, up and down, on Sunday morning, I got a phone call. My mum was dead. I can't believe what was going on in the country. How nobody, especially 9 months after the start of the pandemic, hadn't learned about PPE, weren't actually doing anything to prevent it spreading. How a hospital trust didn't have a policy to test people. All I got was an apology. Apologies don't replace lives.
Thank you. I don't know if anyone did leave. I think maybe one bereaved left. Ms. Cartwright.
Thank you. My lady, the impact films that are shown at the beginning of each module are just one of the ways in which the inquiry ensures a wide range of accounts are heard. On behalf of Module 7, we thank all of those who contributed to the extremely moving impact film we've just watched. The last of those who told their stories on the video, Hazel Gray, who lost both parents within just over a month of each other, will give further impact evidence on behalf of COVID bereaved Families for Justice Northern Ireland tomorrow, followed by impact evidence from Nicola Boyle on behalf of Scottish COVID bereaved. This afternoon we will hear impact evidence from Professor Fulop on behalf of COVID bereaved Families for Justice UK and Anna Louise Marsh-Rees for COVID bereaved Families for Justice Cymru. Turning then to deal with Every Story Matters record. The Module 7 Every Story Matters record analyses and brings together 44,775 stories submitted online and 340 people's stories shared during research interviews and group discussions. We are grateful to the individuals, groups and organisation who have given us feedback, ideas and helped us to hear from a wide range of people. They include FEMHO, the TUC, Long COVID Kids, Long COVID Scotland, Long COVID SOS, Long COVID Support, Clinically Vulnerable Families, Sign Health and the Royal National Institute of Blind People. My lady, may I formally seek your permission to adduce the record into evidence and to be published?
It may be published. Thank you.
Thank you, my lady. Contributors to the Every Story Matters record describe experiences of test, trace and isolate, which I'll now abbreviate to TTI, that echo those described on the impact film as to structural injustices, marginalisation and barriers and issues of accessibility. My lady, I'll quote just 4 examples at the outset, and again, as with the impact videos, some of the content of these 4 accounts, some may find distressing. A clinically vulnerable person stated, "When information came to light about government scandals and people were getting tired of strict isolation rules, I think that's when it got to a stage where people started rebelling and people started saying no. Enough's enough. I think it got to a stage, I'll be totally honest with you, people were going, do you know what? If I'm going to die, I'm going to die with all my family around me. A domestic abuse survivor stated, I self-isolated for myself for 11 days. Isolation is really hard compared to anything you know. Taking tests is even okay. You know, going to hospital is okay. But isolating yourself away from everybody is not okay. Because you know you can't live without talking to, without looking at anybody, or without talking. From a carer, I suppose that if you did have to isolate, you would still get paid rather than... There's an awful lot of people in industry that don't have sick pay. So you're having to isolate for whatever reason, they just weren't paid for 2 weeks. And finally, from another Every Story Matters contributor, I remember people saying, I can't test, because if I test and I'm positive, I can't work. And if I can't work, I can't support my family. You can understand them making those choices, rightly or wrongly. You can understand they've got to provide for their family. My lady, having made those few introductory remarks, may I introduce those who appear before you. The representation of the core participants in no particular order are the following. COVID Bereaved Families for Justice UK, represented by Mr Weatherby, King's Counsel. Northern Ireland COVID-19 Bereaved Families for Justice, represented by Mr Wilcock, King's Counsel. COVID-19 Bereaved Families for Justice Cymru, represented by Ms Parsons. The Federation of Ethnic Minority Healthcare Organisations, represented by Mr Thomas, King's Counsel. The Trades Union Congress, represented by Mr Jacobs. The Cabinet Office by Mr Strachan, King's Counsel. The Department of Health and Social Care, represented by Mr Stein, King's Counsel. The Northern Ireland Department of Health, represented by Ms Myrna King's Counsel. The Welsh Government, represented by Mr Kinnear. Local Government Association and the Welsh Local Government Association, represented by Ms Stober. The Department of Education, represented by Ms Ward, King's Counsel. The Chancellor of the Duchy of Lancaster, represented by Ms Studd, King's Counsel. The Department for Transport, represented by Mr Mertens. His Majesty's Treasury, represented by Mr Block, King's Counsel. UKHSA, represented by Mr Rowett, King's Counsel. Baroness Arlene Foster of Agadrumsey and Paul Given, represented by Ms Ellison. Ms Michelle O'Neill, MLA, the First Minister of the Northern Ireland Executive, represented by Ms Quinlivan, King's Counsel. NHS, National Services Scotland and Public Health Scotland, both represented by Mr McConnell, King's Counsel. Scottish Health Boards, represented by Mr Pugh. Public Health Wales, represented by Ms Powell, King's Counsel. NHS England, represented by Mrs Crabtree. And the Scottish Ministers, represented by Ms Drysdale, King's Counsel. Module 7 has been particularly conscious during the preparations for these hearings of just how hard all of the legal teams and witnesses have been working to cooperate with the requests made by the Module 7 inquiry legal team and of the competing demands caused by the modular nature of this inquiry. 190 witnesses, including many organisations, have provided statements, and as you've already said, my lady, 41 of them will give oral evidence over the next 3 weeks. We are grateful to each and every person or organisation for their contribution to Module 7's substantial amount of evidence, especially to those who've contributed and or will contribute to other modules. My lady, when you opened the Module 2 main evidence hearings on the 3rd of October 2023, you said as follows: the need for me to reach conclusions and make recommendations to reduce suffering in the future when the next pandemic hits the UK is pressing. I say when the next pandemic hits the UK because the evidence in Module 1 suggested it is not if another pandemic will hit us, but when. The more witnesses we call in any module and the longer the hearing takes, the greater the delay in making recommendations, and the greater the delay in hearing other important modules investigating, for example, care homes and children and young people. Module 7 is grateful for the care and thought that has clearly gone into the witness statements and submissions that have been provided. Core participants and a great many witnesses, informed by significant expertise with relevant knowledge and experience of matters relating to the system of test, trace and isolate, have provided insightful comments as to the legacy of TTI and have proposed recommendations for your consideration. Beyond those, you'll hear live evidence from in Module 7. You have statements and evidence from many others. My lady, you will wish to take into account all of the written statements and documents that are put into evidence, as well as the oral evidence heard during the Module 7 hearings, as summarised in a list of statements that will in due course be uploaded to the website. But in short, my lady, they consist of UK decision makers, NHS England, NHS Digital, Duncan Selby, Professor Newton, decision makers from Wales, Northern Ireland and Scotland, statements from those from local government and health, from education, justice and enforcement, impact organisations and individuals, statements from those dealing with equalities, private suppliers, societies, associations and academic institutions, SAGE and independent SAGE scientists, and data and statistics. My lady, you have stated your commitment in meeting the aims of the UK COVID-19 inquiry to investigate the unequal impact of the pandemic on different categories of people across the UK, including but not limited to those with protected characteristics under the Equality Act 2010 and equality categories under the Northern Ireland Act 1998. My lady, you've been absolutely clear that the vital issue of the impact of the pandemic and the response to it on at-risk or vulnerable or marginalised people and on ethnic minority groups has been at the heart of the inquiry since its inception. Module 7 has asked all witnesses to provide relevant evidence of that which is outlined in the inquiry's equalities and human rights statements. Namely, did decision makers consider the impact of policy decisions on each of these groups? And were the decisions taken as a result adequate in mitigating the impact of the pandemic on these groups? It has been said by a number of witnesses and was said to you in the written submissions of COVID Bereaved Families for Justice UK, prepared for the first preliminary hearing of Module 7 in June of 2024, and repeated in a number of the written submissions you have received, my lady, for this hearing, that the work of Module 7 was one of the most critical modules in the entire inquiry. My lady, your observations of the need to make recommendations as soon as possible was never more prescient. Nearly 5 years ago, in May 2020, separate TTI strategies began to be launched across the 4 nations of the United Kingdom. My lady, within your Module 1 report, you stated, the building blocks and essential structure of the test and trace systems established by the UK government and devolved administrations during the pandemic should be maintained so that these systems can be rapidly restored and adapted for use in the event of a future outbreak. Lord Bethell, Minister for Technology, Innovation and Life Sciences, and who had junior ministerial responsibility for the establishment of TTI, and from whom we will hear evidence in week 2, in his statement for Module 7, dated the 16th of April of this year, provides his view that the work of this module is of critical importance, possibly the most important module for our future response to the pandemic. Because in the last 3 years, we have gone backwards, not forwards. The diagnostic infrastructure is dismantled. The data spine is closed down. The UK diagnostic infrastructure has reverted to a small-scale, undercapitalised, science-led cottage industry. Our public health infrastructure, particularly the local representation, is weaker than ever. There is little surveillance of domestic or foreign pathogens, and the social habits around home testing and regular health screening have gone backwards. My lady, in the words of Anna, who we saw on the impact video, who was working in a testing laboratory, TTI capacity needs to be resourced, and we can't run on the fumes forever. My lady, a brief observation on practicalities for this hearing, on all of the hearings over the next 3 weeks. Module 7 hearings over the next 3 weeks are being recorded and live streamed to other locations. This allows the hearing to be followed by a greater number of people than would be able to be accommodated within this hearing room. My lady, as you well know, it goes a considerable way to satisfying the obligation set out in Section 18 of the Inquiries Act to take such steps as you consider reasonable to ensure that members of the public are able to attend or see and hear a simultaneous transmission of these proceedings. The broadcasting of this hearing will be conducted with a 3-minute delay. This provides the opportunity for the feed to be paused if anything unexpected is aired, which it should not be, and we do not expect that to arise over the course of today, but I mention it so that those who are following proceedings from further afield can understand the reason for any such short delay during the course of Module 7's next 3 weeks. My lady, could I very briefly display on the screen the outline of scope for Module 7, which is well known to you, my lady, and all of those in the hearing room. Thank you. The outline of scope for Module 7 states that it will look at and make recommendations on the approach to testing, tracing and isolation adopted during the pandemic in England, Wales, Scotland and Northern Ireland from January 2020 until 28th of June 2022. This includes Test and Protect Scotland, Test and Trace England, Test, Trace, Protect Wales and Test, Trace and Protect Northern Ireland. And again, in high-level summary, my lady, this module will consider the policies and strategies developed, decision made by key bodies, the availability, use and effectiveness of different test, trace and isolate technologies, the structure of the test, trace and isolate system and the cost, enforcement, financial and practical support to those required to isolate, and the availability and use of data in decision making. And finally, by way of the 5th paragraph, and perhaps of significant importance, the preservation of infrastructure, capacity and research to improve and develop test, trace and isolate schemes for future pandemics. Some of the questions that the inquiry in Module 7 will be exploring in the evidence include, sorry, that can be removed from the screen, thank you. What policies and strategies for test, trace and isolate were developed and deployed between January 2020 and June 2020 in England, Wales, Scotland and Northern Ireland? And how did they vary across the 4 nations? Were the policies and strategies deployed effective at meeting their stated objectives? Were the strategies and policies adopted developed with sufficient knowledge and regard had to asymptomatic transmission? Did the development of the overarching strategies and policies take account of the public sector equality duty? And how effective were any steps taken to mitigate unequal impacts on the general population across the United Kingdom, and in particular vulnerable groups? How effectively were the adopted policies and strategies communicated to the general public? How did available data and strategies or expert advice inform the development of the policies and strategies? How effectively was technology used in the rollout of the test, trace and isolate system? How effective was contact tracing? And did it adequately utilise existing and local infrastructure? How effective were the tools in place for enforcing and monitoring isolation? Were appropriate steps taken to support people to comply with test, trace and isolate? And finally, what recommendations can be made for future pandemics? My lady, a more detailed list of the issues in Module 7 has been shared with the core participants. My lady, I will now provide a brief summary of some of the facts, which are by no means exhaustive, but I'm simply going to try and pick out some of the things that provide some of the foundation for the thematic issues. The emergence of the COVID-19 pandemic presented the United Kingdom government and the devolved administrations in Scotland, Wales and Northern Ireland with an unprecedented challenge in respect of testing strategy and the structure and response. The response to the COVID-19 pandemic required the expertise, knowledge and research of medical clinicians and the scientific community, including from specialists in infectious disease, virology, pathology, the microbiology community, epidemiologists, modelers, statisticians, behaviourists, and public health to inform decision-making. The devolved nations of the United Kingdom have authority and responsibility for public health in their own jurisdiction, and Module 7 provides an opportunity to examine the coordination between the devolved nations and Westminster to achieve an effective test, trace and isolate response. We will need to consider the full range of circumstances when designing a shared testing system. Data and health systems differ across the 4 nations. Testing policy and delivery is complex, with multiple interacting systems and needs, and the need to work collectively with colleagues from across the United Kingdom, across the relevant sectors or organisations involved, and while enabling appropriate governance within each nature for operational delivery and devolved responsibilities. Could I ask please to be displayed INQ 000587455. My lady, this is a high-level summary of test, trace and isolate across the United Kingdom in response to the pandemic. My lady, I'll display it for a little time as I continue. It will be then taken down, but a lot of the dates that form part of my summary are from this summary, but I won't keep asking for it to be displayed, but essentially these are the dates that are being used for this opening. Developing diagnostic tests is an urgent priority for the international community once a novel infectious disease emerges. The same was true for COVID-19. In January 2020, just after the publication of the first genetic sequences of SARS-CoV-2, researchers used the data to build molecular tests for the virus. The coronavirus COVID-19 testing programme was developed during the pandemic. You have already heard evidence pertaining to preparedness in Module 1 and published your findings in your Module 1 report on resilience and preparedness of the UK in July 2024. Within that report, you found there was a damaging absence of focus on the measures, interventions and infrastructure required in the event of a pandemic. In particular, a system that could be scaled up to test, trace and isolate in the event of a pandemic. Module 7 will focus on the development of TTI and the timing of that development in response to the COVID-19 pandemic. During the pandemic, a number of types of COVID-19 tests were used. These were initially the reverse transcription polymerase chain reaction tests, more commonly known as PCR tests, which were developed early in the pandemic in the UK with tests available in small numbers from January 2020. Later tests include the rapid antigen or lateral flow device, LFD, and antibody blood tests. Other testing methods, including reverse transcription loop-mediated isothermal amplification, RT-LAMP, and other testing functions were also explored, such as wastewater testing. Work to develop testing capabilities began as soon as the genetic sequencing of SARS-CoV-2 was published in January 2020, and the workup of a new PCR diagnostic test was commenced. China released the first viral genome sequence on the 10th of January 2020, and on the 12th of January 2020 deposited 4 further genomes in the viral sequence database curated by the Global Initiative on Sharing All Influenza Data. Using this genome sequence and information from related viruses, Public Health England, in collaboration with lab partners in Europe, the UK and Hong Kong, were able to develop a specific PCR test for COVID-19 without any biological virus material. Public Health England, as it then was, in 2020, was an executive agency of the Department of Health and Social Care until it was replaced by the UK Health Security Agency and Office for Health Improvement and Disparities in October 2021. It was responsible for all aspects of public health. The PHE assay was available and in use from the 21st of January 2020, and the methodology was shared publicly on the 23rd of January 2020. Testing had been among the topics discussed at a precautionary scientific advisory group for emergencies SAGE meeting on the 22nd of January 2020. My lady, you've heard much about the SAGE organisation and its subgroups, but for a moment, can I briefly display an organogram of SAGE and its subgroups, please? INQ 000 587 458. And my lady, it needs no introduction to yourself, but it might assist those following. The minutes noted that the UK was days away from a specific test which is scalable across the UK in weeks. The sensitivity of the test, it was said in that meeting of the 22nd of January, is currently unknown. There are conflicting reports of the sensitivity of diagnostic tests from upper respiratory tract sampling. And SAGE agreed that the criteria proposed by DHSC and PHE for testing potentially infected individuals were appropriate, namely those presenting with symptoms of what was then being called WNCOV and a history of travelling to or living in Wuhan in the 14 days prior to symptom onset. By the 28th of January 2020, SAGE had confirmed that a PCR test would be available within days. This was initially limited to 400 to 500 tests per day. Throughout the initial phase, the decisions taken by the DHSC and PHE were supported by advice from SAGE, Scientific Pandemic Infections Group on Modelling, SPIEM, Scientific Pandemic Insights Group on Behaviour, and the available data at the time. That can be taken down, please. The Public Health England assay was used at the PHE Colindale laboratory to diagnose the first case in England on the 31st of January 2020. PHE isolated and grew the SARS-CoV-2 virus from the first UK diagnosed case, which provided essential control material for the expected use of the PHE assay, which on the 10th of February 2020 was rolled out to 12 PHE labs across the United Kingdom. Shipments of live SARS-CoV-2 virus containing control materials from PHE Colindale were sent to partners in academia, other government institutes and industry, began on the 17th of February 2020 as soon as the material was available, supporting the development of commercial diagnostic assays and wider capability. At this point, there were still challenges relating to how the SARS-CoV-2 virus could be handled. The Advisory Committee on Dangerous Pathogens, ACDP, sets the classification of biological agents according to their level of risk of infection to humans. Biological agents are categorised into 4 hazard groups from 1 to 4, with 4 being the highest. Categorisation allows for measures to be put in place to control substances that are hazardous to health. In January and February 2020, laboratory work on SARS-CoV-2 was being done at containment level 3, 1 step down from the highest containment level. On the 13th of February 2020, the Advisory Committee on Dangerous Pathogens provisionally classified SARS-CoV-2 as a containment level 3 pathogen. This meant that samples from individuals with suspected or confirmed COVID-19 had to be handled in closed environment and applying stringent safety measures. This made working with the pathogen more resource intensive and required specialist facilities and trained staff and limited the laboratories that were able to process tests for COVID-19. The need to work at containment level 3 was a brake on the expansion of testing. On the 28th of February 2020, PHE, through the Health and Safety Executive, formally asked the Advisory Committee on Dangerous Pathogens for permission for testing to be carried out at a lower level of containment provided certain conditions could be met to ensure safety. And on the 1st of March 2020, the Health and Safety Executive and ACDP agreed to a PHE recommendation that work on the variants could be done at that lower containment level of 2, on the condition that appropriate controls were put in place at testing laboratories. This decision meant that PCR tests could now be processed more widely across the National Health Service, university and commercial laboratories, giving more options for increasing testing capacity, ultimately allowing for a significantly increased level of community testing. On the 8th of March 2020, Public Health England reported to the Secretary of State for Health that the current testing capacity within PHE was 2,100 tests per day. It was predicted that with the addition of a first phase of NHS laboratories, the capacity would increase to 4,500 tests per day over the next 4 weeks. The addition of NHS labs in all 29 pathology regions was predicted to add an additional 3,000 to 4,000 tests, giving a total of 7,100 to 8,000 tests per day. Throughout this period, Public Health England have been working with large-scale diagnostic manufacturers to develop scalable diagnostic tests. My lady, you may recall that in Module 3, you asked Sir Chris Wormold if the UK had the necessary infrastructure to be able to put into place swiftly a scaled-up system of test and trace. Module 7 will fully explore this issue. On the 12th of March 2020, the risk level to the United Kingdom was raised from moderate to high as a consequence of the increase in transmission. The inquiry is now well aware from the work of earlier modules that widespread testing and contact tracing stopped on the 12th of March 2020. Testing is a vital tool in responding to a pandemic, yet the governments of the United Kingdom abandoned community testing at this early stage of the pandemic. At COBRA on the 12th of March 2020, Professor Whitty stated that once the policy of 7-day self-isolation was in place, the plan would be to stop all testing of people entering into self-isolation and to stop all contact tracing from other geographical areas. Before the COVID-19 pandemic, PHE and NHS contact tracing systems were designed to respond to outbreaks and incidents, including those of national and international impact. Directors of public health within local authorities had existing systems and expertise for contact tracing. But on the 12th of March 2020, all 4 nations agreed to move from contain to delay, and the first restriction of self-isolation for people with mild COVID-19 symptoms to self-isolate was announced by the Prime Minister, Mr Johnson. Module 7 will explore the decision on the 12th of March 2020 to stop testing and contact tracing, and including in the context of, firstly on the 14th of March 2020, PHE forming a partnership with Roche Diagnostics to deploy its new SARS-CoV-2 PCR test. This test could be processed using Roche high-throughput PCR processing systems, which are already in place in most public sector health organisations, for example, NHS hospital laboratories in large NHS trusts. By the end of April 2020, the Roche test had increased total daily PCR capacity by approximately 5,000 tests per day. But my lady, the decision of the 12th of March 2020 also needs to be seen in the context of the announcement on the 16th of March 2020 of the Director General of the World Health Organization, Dr. Tedros Ghebreyesus, stating that we have a simple message to all countries. Test, test, test. Test every suspected case. If they test positive, isolate them and find out who they've been in close contact with up to 2 days before they develop symptoms, and test those people too. A note to this advice on the 16th of March 2020 included that the World Health Organization recommended testing contacts of confirmed cases only if they showed symptoms of COVID-19. On the 16th of March 2020, individuals with the symptoms of COVID-19 and their household contacts were advised to stay at home. The guidance detailed that if you lived alone and you had symptoms of coronavirus illness, however mild, there was a need to stay at home for 7 days from when your symptoms started, and that if you live with others, you or one of them had symptoms of coronavirus, then all household members must stay at home and not leave the house for 14 days. On the 17th of March 2020, the Department of Health and Social Care took over responsibility for scaling up testing from PHE, Public Health England. The inquiry will examine in detail what followed. On the 23rd of March 2020, the first nationwide lockdown was announced. Until May 2020, only those hospitalised or included within specific outbreaks were tested, and at that point all symptomatic individuals became eligible for testing. Statistics from DHSC indicated that by the 23rd of March, the number of cases verified by positive tests in the UK was 6,650, with 77,295 negative tests. Estimates from the first few hundred study and the COVID-19 hospitalisation in England surveillance system showed the true number to be in the region of 500,000, with over 100,000 of those infections occurring on the day that lockdown began. New cases were doubling approximately every 2.8 days. Priorities for testing of healthcare workers and frontline workers will be explored in Module 1. Could I ask please to be displayed INQ 000 459. My lady, it has been said that to implement effective test, trace, isolate and support systems, or to win the game, countries must ensure that those with COVID-19 progress as quickly as possible from the start to the finish. If this does not happen, new cases will appear and another lockdown will be needed. Countries can do this most effectively by putting in place measures that enhance the ability to find, test, trace, isolate and support. That is, landing on ladders, and by avoiding setbacks that occur due to insufficient capacity in the health system and beyond, avoiding snakes. My lady, we will look at this snakes and ladders and the approach with Professor McKee tomorrow. That can be taken down, please. And could I ask for the chronology again to be displayed? INQ 000 587 455. My lady, on the 25th of March 2020, Northern Ireland introduced the discretionary support self-isolation grant. The expert report of Professor Matcham provided for Module 7 provides a detailed analysis of self-isolation support schemes developed over time. Test and trace support in England was introduced in September 2020. In Scotland, the self-isolation support grant in October 2020. And in Wales, self-isolation support scheme in November 2020. Module 7 will examine how the isolation support schemes operated and the effectiveness of these as part of the system of test, trace, isolate across the four nations. Continuing with the chronology from the 25th of March 2020. PHE continued to lead work to develop an expanded contact tracing system, including continuing to develop the contact tracing and advice service system for implementation once wider testing was available, CTAS. The contact tracing and advice service worked with a digital tool in February 2020 to help manage the increasing demand for contact tracing. Contact tracing and advice service enabled PHE to contact confirmed and possible cases of COVID-19, their contacts and returning travellers to complete contact tracing. Cases and contacts were directed to a web-based form to answer contact tracing questions, and where straightforward, they could complete the contact tracing journey through CTAS, which provided advice on self-isolation as required. This formed a part of a broader programme of work for which DHSC was responsible, including the National Testing Programme as part of the United Kingdom Government's Test, Trace and Isolate strategy. In April 2020, the Department of Health and Social Care created the National Testing Programme as part of the government's ambition to scale up testing capacity and distribute tests more widely through a phased approach beginning with patients, NHS workers and their families, other critical key workers, and then expanding to the wider community over time. In April 2020, the government's testing strategy was launched, linked to the opening of the first Lighthouse testing laboratory. The National Testing Programme, NTP, refers to both the programme and the unit charged with delivering that programme. The National Testing Programme initially operated within the Department of Health and Social Care and brought together supply chain, logistics and procurement expertise from across government, the military and private sector. It was integrated into the TTI strategies upon their establishment in May 2020 across the 4 nations. My lady, as you're well aware, on the 2nd of April 2020, Mr Hancock set the target of running 100,000 tests a day by the end of April. The Francis Crick Institute, the Crick, is the largest biomedical research institute under one roof in Europe. The inquiry will hear evidence from Sir Paul Nurse, the Crick director, on Thursday this week, that this large-scale big ships approach introduced by the Lighthouse Laboratory new scheme was prioritised and the little boats approach ignored, despite the suggestions of Crick scientists and others from universities and laboratories with testing facilities who were available and ready to support complementary small-scale efforts throughout the country in the provision of PCR testing and with the equipment, skills and expertise. In a statement provided to Module 7 from the Royal College of Pathologists, it is detailed how many NHS clinical diagnostic laboratories and also universities could have had capacity to carry out more testing than they did, but testing was outsourced to private laboratories, which were not all subject to the same high pre-symptomatic, asymptomatic and post-symptomatic transmission of SARS-CoV-2, Joint British Infection Association, Healthcare Infection Society and the Infection Prevention Society and Royal College of Pathologists guidance standards of quality assurance routine in NHS laboratories. The Royal College of Pathologists provide the view that use of existing clinical laboratories and of university laboratories and their skilled staff would have been much more financially efficient, and that there was a missed opportunity to invest this resource in equipment and infrastructure for existing NHS labs, with huge resources going to temporary, often lower quality facilities in the private sector instead. The government strategy was to support Lighthouse laboratories and not smaller, local, more agile testing. It is still unclear and will be investigated by Module 7 who proposed this approach, who approved it, and why full consideration was not given to more local, small-scale efforts, which could have been put in place more rapidly. Similarly, a statement provided to Module 7 from the Microbiology Society records, the Society believes that the government did not sufficiently engage with universities and research institutes to understand their capacity and ability to support in the scaling up of testing, despite offers from the Society and its members. When Mr Hancock announced the 5 pillars of testing, including the intention to develop a UK-wide diagnostic infrastructure, frustration was felt at the delay, but the community was willing and prepared to support. However, a lack of clarity on how to help and a lack of support by the government on local testing systems to overcome the lack of communication between NHS and other laboratories meant that there was still significant capacity wastage by the autumn of 2020. The Society further does not understand why the government did not consider capacity in universities for the development of reagents, even if the diagnostic capacity itself was not used by universities would have been well placed to support reagent production. My lady, that quote from the Microbiology Society referenced Mr Hancock's 5-pillar approach. And could I ask please for INQ 000106460 and page 9 internally to be displayed, please. Thank you. On the 4th of April 2020, the Department of Health and Social Care published its 5-pillar testing plan, including the target to increase the testing, as I've already said, to 100,000 tests a day by the end of April. My lady can see the 5 pillars represented by the strategy. Pillar 1, to scale up NHS diagnostic testing aimed at critical key workers. On its announcement on the 4th of April, Pillar 2 was said to be a partnering with universities, research institutes and commercial partners to create capacity for mass testing for the general public. Pillar 3 was to develop antibody testing in cooperation with a private sector provider. Pillar 4 was to be surveillance testing to learn more about the disease and help develop new tests and treatments. And Pillar 5 was the diagnostics national effort to build a mass testing capacity at a completely new scale. The 5th pillar was designed to grow the UK's diagnostics industry substantially and to rapidly create a new mass testing capacity. This relied heavily on the introduction of lateral flow device tests, which were developed, tested and trialled during mid-2020 and introduced for use in the National Testing Programme in late 2020. The inquiry will explore the extent to which the pillars were implemented as part of the system of TTI. And if that could be taken down, please. Continuing then with the chronology as we move towards May. The first of a network of drive-through testing sites, regional testing sites, was set up on the 25th of March 2020. By the 23rd of April 2020, there were 30 such sites, and their number continued to increase thereafter. On the 9th of April 2020, the first Lighthouse Laboratory was launched. A Lighthouse Laboratory network was established to increase testing capacity, with facilities brought online to manage initial testing growth and then variable demand. Could I ask please for INQ 000587456 to be displayed? Thank you. The Lighthouse Labs were higher throughput diagnostic testing facilities purposefully created to only process COVID-19 samples following input from PHE specialists and other specialist stakeholders. The first such laboratory was set up in Milton Keynes, followed by laboratories at Alderley Park, Cheshire, and Glasgow in April 2020. The Lighthouse laboratories later became part of the NHS Test and Trace laboratory network. Increasing access to tests required a commensurate increase in laboratory capacity so that the return tests could be analysed. PHE played a key role in supporting the National Testing Project to establish the Lighthouse laboratories. Could that be taken down, please? Briefly, in respect of mobile testing units, these were manned by military personnel and first piloted on the 17th of April 2020, with the first unit becoming operational on the 19th of April 2020. The use of mobile testing units meant that those who could not drive to a regional testing site had access to testing. They were deployed in response to requests from local authorities or to locations such as care homes, prisons or factories where there was a demand for testing. Once on site, they could begin work within 20 minutes. Mobile testing units played a role in investigating hot areas of new variants and/or rapid epidemiological increases, so providing additional support, it is said, at a local level. It is clear that from the middle of March 2020, the Department of Health and Social Care and Lord Bethell, who was mentioned earlier, were engaging with a number of private companies, including Deloitte, to establish the infrastructure for the system of TTI. Could I ask, please, for INQ 000587457 to be displayed? And my lady, this gives a snapshot of the number of private companies that were involved in the establishment of the test, trace and isolate system, including those who were set up and responding in respect of testing, and those companies and organisations assisting with contact tracing. My lady will see within that image that companies Royal Mail and Amazon, there was a delivery service that was set up for sending PCR testing kits to homes, designed with Deloitte and industry partners, including Royal Mail and Amazon. The home delivery service meant those not able to travel to a test location, such as a regional testing site, could still take the test. The inquiry will examine the timeline of eligibility for tests, how effective the systems were, and how accessible tests really were. PHE provided public health guidance and expertise to the National Testing Programme, initially as testing became accessible to staff across the NHS and their household members, including individuals working in the NHS, outside acute care, for example in mental health, primary care and community services. Please can that be taken down? And could we return to the chronology? And my lady, perhaps if I can briefly deal with symptomology before we take a morning break. My lady, will see from the overview chronology that on the 18th of May 2020, all symptomatic individuals were available for testing. Anosmia, meaning loss of smell, and ageusia, loss of taste, was added to the list of symptoms that require 7-day isolation on the 18th of May 2020. On Monday next week, the inquiry will hear from Professor Tim Spector. The Zoe COVID symptoms study was initiated in March 2020 and provided data from those who joined through an online app and self-reported their presence or absence of symptoms, a subset of which were confirmed through diagnostic tests. On the 24th of March, one of the symptoms for selection added to the Zoe symptom study was loss of smell or taste. By the 27th of March 2020, the Zoe study had identified that the symptoms of loss of smell or taste were strongly associated with testing positive for COVID-19, and had also identified that in the elderly aged over 75, acute confusion could be the only presenting symptom requiring differing guidelines for testing in frail older people. One of the issues Module 7 will explore is why it took until the 18th of May 2020 for a loss or changed sense of normal smell or taste to be recognised formally as a symptom of COVID, and whether the presentation of symptoms in older people was recognised. We will also explore the knowledge and understanding in respect of asymptomatic transmission of COVID. My lady, would now be a convenient moment to take the morning
Certainly.
break. Thank you, my lady.
Thank you very much. I shall return at midday. Ms. Cartwright.
My lady, thank you. Before moving to the TTI strategies, can I apologise to Ms Mitchell, King's Counsel and Scottish COVID bereaved in doing the introductions. I omitted to welcome her to the room, so I apologise sincerely to her and her...
How could you, Ms. Cartwright? Sorry.
My lady, then, for the purposes of concluding my address, I want to focus finally on the TTI strategies developed in May 2020 and then give an indication of some very top-line things in respect of the system till its conclusion. My lady, the scale of the task of Test, Trace, Isolate was underpinned by SAGE agreeing at its 32nd meeting on the 1st of May 2020 that in developing an effective test and trace system, at least 80% of contacts of an indexed case of COVID-19 would need to be contacted for the system to be effective. SAGE had high confidence that isolation of those contacts within 48 hours would be desirable. On the 4th of May 2020, the Department of Health and Social Care announced the first phase of Test, Track and Trace, a programme aimed at controlling the spread of COVID-19 as the UK began to ease lockdown restrictions. The programme was designed to work alongside existing local public health teams and emerging digital solutions to enhance contact tracing efforts. The government launched a trial of the NHS COVID-19 app alongside traditional contact tracing methods on the Isle of Wight to assess its effectiveness before a wider rollout. The Isle of Wight was a suitable first test location because it was an island with a sizable population served by a single NHS trust. The app was designed to integrate with enhanced contact tracing services and swab testing for those with potential COVID-19 symptoms to help minimise the spread of COVID-19. The original NHS version of the app faced challenges relating to Bluetooth accuracy and compatibility across devices. New technology developed by Apple and Google altered approaches which could be taken to app-based contact tracing. As a result, NHS Test and Trace went on to work with external contractors on a new NHS COVID-19 app using the new available technology. And my lady, we will hear from Professor Christoph Fraser in respect of the app development tomorrow, and Mr Gould and Mr Thompson on Friday. We will explore in Module 7 how the apps developed and implemented differed across the 4 nations and the systems of contact tracing utilised, including digital and manual contact tracing, and if it suitably and effectively utilised the existing role for the Associate Directors of Public Health. My lady, I'm now going to give a summary of each of the systems and strategies that were implemented across the 4 nations in May of 2020. And can I start, please, with Scotland? And can we please display INQ 587500? Thank you. On the 4th of May 2020, Scotland published its Test, Trace, Isolate support strategy. Nicola Sturgeon set out that the Scottish approach to test, trace, and isolate support and the extensive work that was underway to prepare for its implementation on the 4th of May, stating, "Our behaviour matters, and our choices and willingness to make sacrifice to help keep people in Scotland safe will be crucial. A key aspect of this next phase is a test, trace, isolate support approach. We will test people in the community who have symptoms consistent with COVID-19. We will use contact tracing, a well-established public health intervention, to identify the close contacts of those cases who may have had the disease transmitted to them. We will ask and support those close contacts to self-isolate, so that if they do develop the disease, there is less risk they will pass it on to others. And we will make sure that support is available to enable people to isolate effectively. However, it is important to stress that test, trace, isolate support will be most effective when levels of infection are low, lower than now, and stay low, and that its success relies on all of us knowing and agreeing what to do if we have symptoms and being prepared to self-isolate when advised to do so." Could that be taken down, please? And my lady, you can see a very high-level summary on that image that related to Scotland's system. Turning then, please, to Wales. Thank you. On the 13th of May 2020, Wales published its Test, Trace and Protect plan. And on that date, Mr Gethin, then Minister of Health for Health and Social Services, said, "We all want to be able to return to normal life as quickly as possible and to ease restrictions further. The science will guide us about when that happens. Our Test, Trace, Protect strategy will be a key element in helping us to do that by enabling us to quickly identify people with coronavirus symptoms, to identify any new hotspots and to isolate as many contacts as possible." And it was said that that plan included increasing testing of critical workers to enable them to return to work, a new system of home testing for the public if they have coronavirus symptoms, a new app to track symptoms in the general population and contact others who have symptoms or have tested positive. And it detailed at that time in Wales that the testing capacity stood at more than 5,000 tests a day, with 6 drive-through testing centres, 8 mobile units, and a number of community testing centres throughout Wales. It was said that testing capacity was to be increased to up to 20,000 tests a day by drawing on the UK-wide scheme as the Test, Trace, Protect strategy is implemented. Could that please be taken down? And could I ask that the similar image for Northern Ireland be displayed? Thank you. In Northern Ireland, on the 27th of May 2020, the COVID-19 Test, Trace and Protect strategy, saving lives by minimising SARS-CoV-2 transmission in the community, was published by the Northern Ireland Department of Health. The strategy, as of the 27th of May 2020, detailed that, in line with the rest of the United Kingdom, that the PHA were conducting rigorous contact tracing for all cases of COVID-19 until the 12th of March 2020. On the 12th of March, the UK moved from the containment phase to the delay phase. The focus of our efforts then shifted from individual contact tracing to wider measures, including advising all of the public to immediately self-isolate if they had even mild symptoms, prevention of spread and social distancing. And that policy detailed that the 4 key elements of Test, Trace and Protect were early identification and isolation of possible cases, clusters and outbreaks, rapid testing of possible cases, tracing of close contacts of cases, and early, effective and supported isolation of close contacts to prevent onward transmission of infection. And it was said that chains of transmission can only be broken if those who could transmit the disease to others are isolated and get the support they need to maintain that isolation. My lady, in the third week of the hearing, we will hear evidence from Professor Arden in respect of her opinion as to the analysis of adherence to behaviours associated with the TTI system. But it was clear that the Northern Ireland strategy had identified the need for support for isolation. My lady, can we then please display in respect of England INQ 587 506? Thank you. On the 27th of May 2020, Matt Hancock announced that the NHS Test and Trace service will be launched on the 28th of May 2020. NHS Test and Trace was funded and supported by the Department of Health and Social Care, and notwithstanding its name, it was not part of NHS England. The Secretary of State for Health and Social Care can designate an organisation as NHS, and decided to do so in the case of NHS Test and Trace. Baroness Dido Harding was appointed to lead the UK Government's programme of testing and tracing following her appointment on the 7th of May 2020 as Executive Chair. Professor Newton of Public Health England continues to provide the professional link into public health expertise, and we will hear from Baroness Harding in the third week of the inquiry. My lady, you're already aware that there was a unique reporting structure within NHS Test and Trace. The Department of Health and Social Care had ministerial accountability for NHS Test and Trace and reported directly to the Prime Minister and the Cabinet Secretary until the 2nd of December 2020. From the 3rd of December 2020 until the 7th of May 2021, the Executive Chair then reported to the Secretary of State. My lady, in respect of NHS Test and Trace strategy in May 2020, it was to test, first of all, increasing availability and speed of testing, to trace when someone tests positive for coronavirus using the NHS Test and Trace with a dedicated contact tracing staff, online service and local public health experts. In respect of Contain, a national joint biosecurity centre was to work with local authorities and public health teams in Public Health England, including local directors of public health, to identify localised outbreaks and support effective local responses, including plans to quickly deploy testing facilities to particular locations. And it was said that local authorities had been supported by £300 million of new funding to help local authorities develop their own local outbreak control plans. And finally, in respect to the strategy Enable, for the government to learn more about the virus, including as the science developed, to explore how it could go further in easing infection control measures. My lady, that is a summary of testing strategies as at May 2020, and each of those diagrams give an overview of the systems that were then adopted across the 4 nations. My lady, briefly, we will hear further in Module 7 in respect of the development of the Operation Moonshot programme. We will also examine the development into the community testing programme, which was published on the 23rd of November 2020 as part of the COVID-19 Winter Plan. Module 7 will look at the differing approaches to enforcement of isolation across the 4 nations. We will also look and examine the universal testing offer as announced in April 2021, my lady, I do apologise. My lady, at its peak, NHS Test and Trace was capable of processing 800,000 PCR tests a day and distributing 900,000. My lady, as part of the universal testing offer, lateral flow devices became key. And my lady, from its conception to winding down in 2022, 15.8 million individuals who tested positive for COVID-19 were contacted, with 31.3 million close contacts of those. 15.8 million people were traced as part of the contact tracing effort. And my lady, you're already well aware that on the 24th of March 2021, the government announced that NHS Test and Trace would form part of the newly created UK Health Security Agency, with that transfer happening and operational effectiveness commencing on the 1st of October 2021. Lady, the total value of contracts awarded to suppliers of consultancy services is a matter you've already heard some evidence about. My lady, you will recall from Module 5 in the evidence of Lord Agnew that there are mixed views as to the operation of some of the private contracts used as part of the TTI system and the cost of the same. The inquiry will explore the use of the private sector and ask if existing infrastructure could have been better utilised rather than the private sector companies to scale up testing and effectively implement contact tracing. And my lady, finally, by way of my opening submissions, a brief comment as to costs. My lady, figures as to costs you've already heard in earlier modules. But my lady, the initial budget for the NHS Test and Trace service, made up predominantly of funding for testing, was 15 billion for April 2020 to March 2021. The November 2020 spending review introduced a further 7 billion of funding to support the rollout of mass testing, as well as the continued increase in testing capacity. This raised the total budget to 22 billion for 2020 to 21. In practice, NHS Test and Trace spent 13.5 billion in 2020 to 21, of which 10.4 billion was on testing. A further 15 billion was allocated to NHS Test and Trace in 2021 to 2022. In conclusion, my lady, Module 7 will investigate each of these systems: Test and Protect Scotland, Test and Trace England, Test, Trace, Protect Wales, and Test, Trace and Protect Northern Ireland, and any variations in the measures adopted by the governments to contain the COVID-19 virus, the reason for any variations, and the timing and implementation of decisions, and the effectiveness of the systems implemented. We will further consider the consistency of decision-making across the 4 nations. But, my lady, principally we will do so through the lens of informing required recommendations that will flow from Module 7 and to help public health efforts to stem the spread of viruses across the UK in any future epidemic or pandemic. My lady, thank you. I think the next opening submissions are to be provided by my learned friend Mr Weatherby, King's Counsel, on behalf of COVID-bereaved Families for Justice UK.
Thank you very much indeed, Ms Cartwright. Mr Weatherby, as you're first up, can I just say this? I do know how difficult it's been, for reasons beyond the inquiry's control, to prepare for these hearings. For everybody, the inquiry team, yes, for the core participants, and I'm really grateful to all of you for the heroic efforts you've been making.
Thank you very much. Anthony Costello, Professor of Global Health at the UCL Institute of Global Health and a former WHO Director, starkly sets out the backdrop to Module 7 in his witness statement at paragraph 66. Talking about the comparative outcomes of the UK and East Asian countries from the outset of the pandemic, he asserts this, and I quote, "Over the next 3 years, East Asian death rates were 5 times lower than the UK. Demographics cannot explain these huge differences. Notably, Japan and South Korea had similar GDPs, life expectancy and age profiles to the UK. If we'd followed the same strategy and achieved the same cumulative death rate by March 2024 as South Korea, 69 per 100,000, rather than the UK 344 per 100,000, we might have prevented over 180,000 deaths. As important, large countries like Japan and South Korea had no prolonged national lockdowns, only in hotspot areas. They had no second waves before a vaccine was available, and new outbreaks were quickly snuffed out by surveillance and isolation of the affected. In setting out the fact that so many lives might have been saved had the UK taken a course similar to East Asian countries, no doubt Professor Costello was not trying to draw an exact comparison or give anything other than a stark headline. But what his evidence does is to highlight that Module 7 is not simply an examination of one aspect of the pandemic response, one aspect of how we might seek to do a little better next time, but an illustration of just how catastrophic the UK's approach to TTIS really was. It started with no planning, no capacity, no contact tracing, lab analysis or isolation infrastructure for anything other than the occurrence of a limited high-consequence disease outbreak. And perhaps most significantly, too little support for those most likely to spread the virus if they did not test and isolate. Compounding the lack of planning was the incompetence of the UK government response and the attempts to pretend that the UK was well prepared. At a Downing Street press conference on 3rd of March, Mr Johnson told us, the public, that the UK had, and I quote, fantastic testing systems and fantastic surveillance of the spread of the disease. This was very far from the truth. Well before the pandemic, in early 2019, a BMJ article had flagged the lack of diagnostics as, quote, one of today's most serious health security blind spots. The problem was long-standing, underinvestment and lack of planning, all political choices. By about the time of Mr Johnson's March press conference, as we pointed out in Module 2, South Korea, a comparable country on many metrics, had undertaken 5 times the number of tests undertaken by the UK. At about this time, as we've heard this morning, the Director General of the WHO, Dr Tedros, very publicly urged the world to test, test and test. As we heard in an earlier module, Dame Jenny Harries, then DCMO for England and now Chief Executive of UXA, told a Downing Street press conference again in March 2020 that the WHO directive was aimed at low and middle income countries. She told this inquiry that the UK had indeed been testing but had no tests left. In his witness statement, Professor Pillay says that at the time, the suggestion that the WHO appeal was aimed at less well-developed countries was, quote, derided by many and suggested to us that the UK COVID response was both complacent and based on a UK exceptionalism. Dame Jenny Harries suggested in her evidence that her comments had been misinterpreted. That, of course, is a matter for you. But the important point for Module 7 is how did the UK, a high-income country, not have adequate testing capacity by March 2020? What Dame Jenny was actually intimating was that having run out of testing capacity, UK policy on testing was led by shortage, not public health strategy or need. As you'll hear, Professor McNally indicates that the UK was, quote, trying to manage COVID blind, while senior public officials were apparently deflecting the real problems of lack of capacity and just about zero pre-pandemic planning by suggesting the WHO advice was really for others. The importance of testing is, of course, all too obvious to see with hindsight. It's clearly set out in some of the expert evidence that you have and will hear in this module. In simple terms, those countries which had good testing provision from the outset had far lower mortality rates and far lower economic damage and social upheaval than those which did not. I've said all this is clear to us in hindsight, but in fact, this was not only obvious at the time, but it had been obvious to many countries for years before the pandemic struck. Professor Pillay says in the final paragraph of his witness statement, and I quote, some areas of the world, including China, South Korea and Taiwan, were able to rapidly respond to the COVID pandemic through infrastructure and testing protocols developed in response to SARS some 20 years previous. Why had the UK not learned those lessons? They were hardly hidden. Professor Costello outlines that the failure to plan, test and trace was partly because what planning there was for flu, and the view, correct or not, that such a pandemic could not be suppressed. That minimal effect theory was adopted by SAGE in January of 2020. What a catastrophic error that was. Not only were there warnings, such as the 2019 BMJ article, but in fact a 2006 WHO paper written in the aftermath of SARS-1, whose authors included Professor Horby from NervTag and Professor Van Tam, both of whom were SAGE members in January 2020, contrasted the different incubation and transmission characteristics of influenza and coronaviruses, concluding that this, quote, allows more time to effectively implement isolation and quarantine measures with respect to the latter. Why was that learning ignored? Whatever the explanation, the results of not learning the lessons of SARS-1 and the approach of other countries then appear to have been compounded by a series of further flawed decisions. Back to Professor Pillay, he asserts that the lack of UK testing capacity led to, quote, highly expensive outsourcing. He goes on to recount a meeting led by Deloitte regarding lab capacity, and according to Professor Pillay, they asked basic questions regarding clinical sampling, and, quote, it was clear that Deloitte had no relevant expertise. This is what happens when there's an absence of planning and where there has been severe chronic under-resourcing for emergencies. Testing and particularly contact tracing are not easy to put in place from a standing start. In our submission, the inquiry should question closely why there was the need for such outsourcing, and in particular, how companies with no relevant experience got the contracts, a point which obviously overlaps with the last module. Was it a fair and efficient process, or was it more cronyism and lobbying? The evidence will show that the UK was quick off the mark in developing tests for COVID, but even here there were problems. Despite what has been said about PHE sharing control material, Professor Pillay asserts that PHE were in fact reluctant to share control material with others, including himself. Why? The sensible solution, of course, was to encourage different approaches, anticipating that some may fail. Indeed, that's what happened when PHE's own assay was found to be flawed with many false negative tests. Even with available tests, the UK had insufficient capacity to manufacture or source what was needed for testing, insufficient labs for test analysis, and insufficient infrastructure to deliver testing. Once again, with insufficient capacity came errors. Of course, once it was realised that the UK had too little lab capacity, it was right to ramp up that capacity howsoever it could be done. But instead of fully utilising existing university and other labs while sourcing and outsourcing for other capacity, it appears that the emergency response was to put all its eggs in the basket of the Lighthouse labs still being established. As we've heard, local public health teams and directors of public health were overlooked with respect to operating test and trace in favour of a national approach, despite these resources fitting with the general civil emergency policy of localising response, and despite the expertise in terms of testing that they already had. Localised approaches taken in countries including South Korea and Germany not only built on existing resources and expertise, but utilised local knowledge and built trust with local populations, essential to a collaborative approach, which included contact tracing and isolation. A factor emphasised by many witnesses, and in particular by the bereaved families, is that with even the best test and trace systems, isolation could only work with adequate financial and practical support. As the evidence will show, the UK was slow off the mark in this regard. They had very low statutory sick pay comparable to similar countries, and according to Professor Costello, initially at least it had the lowest financial provision for those needing to isolate of any OECD country. As a result, it had low compliance rates. It's clear why workers in insecure employment and those on low incomes will be reluctant to test, never mind isolate if positive. The corollary of this is that the failure to provide such support from the outset not only impacted on the spread of the virus, but resulted in massively increased public spending on furlough later on. You will hear from Professor Fulop later, who will tell not only her own account, but refer to those of other bereaved. I won't trespass on that evidence, except to note that it will illustrate that after failing to use TTIS to suppress the spread of the virus initially, the UK compounded that, and as Professor Padgell will tell us, by repeating the mistake and ignoring the urging of the Academy of Medical Science and Independent SAGE to ramp up its approach before the second wave was upon us, once again to devastating human effect. And finally, as in all other modules, we draw attention to the failure of policy and planning in this area to recognise, let alone counter, structural and institutional race and other forms of discrimination, including disability, which led to underserved and vulnerable communities being disproportionately impacted. Thank you.
Thank you very much indeed, Mr. Witherby. Mr. Wilcock.
Forgive me, we're just having to fight over the lectern. Milady, as you know, I appear on behalf of the Northern Ireland COVID bereaved Families for Justice, and I'm going to keep my address to you short for 4 reasons. 1, you already have our written submissions. 2, as those written submissions make clear, many of the broad points made on behalf of other bereaved core participants clearly apply to those from the north of Ireland, and we adopt them. Thirdly, you are already aware of the unique differences between the healthcare and political systems in Northern Ireland and the rest of the United Kingdom from your time in Belfast this time last year. uniquely underfunded and governed by an at times dysfunctional mandatory coalition of parties who share widely divergent views on some of the issues inherent to many of the issues you will examine in this module, such as the nature of acceptable health interventions and policies, let alone the role of the state and national identity. Fourthly, some of the evidence you heard in M2C has already touched upon one of the major controversies in Northern Ireland, in the Northern Irish approach to test and trace, or to testing rather, during the pandemic, namely the decision to, some would say blindly, follow the decision of the UK government to suspend community testing in the early mid-March, on the 12th of March of 2020. In spite of the fact that at that time, as Professor McBride has told you in the statement he has filed for this module, in contrast to other parts of the United Kingdom, there were a relatively small number of confirmed cases in Northern Ireland, and therefore contact tracing there had the potential to have a significant impact on the course of the pandemic and delaying community transmission. This was not a one-size-fits-all situation. The evidence the inquiry will be hearing in relation to the specific Northern Irish response to test, trace and isolate in the next few weeks is confined to 4 witnesses who will all be called on the 21st of May. My clients have noted that none of those witnesses come from the Public Health Agency, which was the lead operational and coordinating body in Northern Ireland for both the testing and contact tracing programme. But having made that observation about the Northern Ireland witnesses you have been able to call as part of this wide-ranging UK inquiry, can I make clear that whilst it is plainly unfortunate, we entirely accept that your ladyship has had to deal with the fact that there was, as you will know from M2C, at the time, at the start of the pandemic, actually no Director of Public Health available in Northern Ireland from the agency. And furthermore, we appreciate that not only have you heard evidence from the present incumbent of that position in M2C, but you have obtained a statement from her in relation to this module, in which she has told you that in the context of the chronic underfunding of the Northern Ireland, of the health service in Northern Ireland, you know so much about, quote, prior to the pandemic, the Public Health Agency was carrying a number of vacancies across its directorates, such that, remarkably you may think, the corporate risk register had to include risks reflecting the seriousness of this position. My lady, you may think this depletion in staffing that you will have read about in the reports must inevitably have affected the Public Health Agency's ability to not only carry out its core functions in relation to public health, never mind the additional tasks that were imposed on it by the role it was given during the pandemic. But Dr. McLean has also told you in her written statement that her understanding is that the Public Health Agency weren't even consulted when Northern Ireland suspended community testing on the 12th of March of 2020. But furthermore, that had they been consulted, she says, in effect, that whilst everyone recognised the burdens that testing was placing on the PHA, and that they would have to carry if testing were to continue in breach of the decision made by COPER on the 12th of March. The decision to follow the English lead on this issue was, and I quote, counterintuitive to public health practitioners. As I say, the one-size-fits-all approach was not appropriate, you may think. But, my lady, the political system in Northern Ireland only came back to life after a prolonged hiatus on the 11th of January 2020. This time last year, you heard Professor McBride tell you that at that stage, testing capacity in Northern Ireland stood at only 40 tests a day. In deciding whether enough was done early enough in the chronology that Ms. Cartwright and Mr. Weatherby have told you about, to expand this capacity, you may, on the 21st of May, want to ask yourself who, particularly in the political system, asked what about that capacity and when did they ask it? in order to decide whether the approach they were taking to expanding capacity inevitably in an emergency situation was appropriate. And given its size and limited existing testing capacity, I don't think that there would be many people in Northern Ireland who would be surprised that the Northern Irish authorities were forced to rely on its existing established relationships with the UK Public Health Laboratory Network when it became apparent that the Northern Irish capacity was sadly so insufficient to adequately combat the spread of our mutation of COVID. And to that extent, even if we choose to make our observations in writing rather than in oral questioning, the evidence you will hear on the expansion of the UK laboratory system is of some relevance to Northern Ireland and the development and analysis of the development of what was called in Northern Ireland Test, Trace and Protect. And my lady, you will hear that across the 4 nations of the UK, the aims of Test, Trace and Isolate, whatever the programme was called, were consistent. And there were broad similarities in the approaches which were taken, with some exceptions, of which I shall at this stage outline just 3. First exception was, inevitably, given its status on a separate island with a shared border with another government in Ireland, the Northern Irish authorities had to use different phone apps and take a different approach. And you will hear about that when you deal with the what I'm going to call the computing evidence in this case. Secondly, you will hear that unlike other regions, adherence to and enforcement of Test, Trace and Protect regulations in Northern Ireland was not straightforward. Possibly because of a combination of its recent history and the wider range of views amongst Northern Irish politicians as to the nature of acceptable interventions, Northern Ireland relied merely on what they called very strong advice to isolate, rather than any legal duty for domestic cases and contacts. My lady, the third difference has been indicated by Ms. Cartwright this morning. In relation to financial support, Northern Ireland implemented a non-repayable discretionary support self-isolation grant, which one of your experts, Professor Macon, has described as significantly different and broader in scope than those delivered across the UK. Malody, this morning we heard the heartrending evidence from one of my clients, Hazel Gray, about the circumstances in which she lost both her parents and the role that the absence of testing can reasonably be thought to have played in their deaths. Tomorrow morning she will tell you not only her story, but some of the lived experiences of other bereaved families in Northern Ireland in relation to this module and the pandemic. You will be moved by those stories, but we don't ask you to listen to them to be moved. We ask you, and nor do we intend by putting that evidence before you foursquarely, to minimise the difficulties or tremendous effort the Northern Irish health and political systems had to put into ramping up testing in Northern Ireland during the pandemic. Because in spite of the inevitable mistakes, neither do we suggest that there were not some things that were actually done well in this module in Northern Ireland. However, as the last witness you will hear from in this inquiry, Professor Deenan Pillay has put in his written statement to the inquiry, when speaking about the UK overall, but the remarks plainly transcend all jurisdictions, one of the most disappointing, indeed in his view disgraceful, outcomes of the Test and Trace programme is the lack of any meaningful legacy or strategy for the next pandemic threat. Disappointing is an understatement, given the rest of that statement. And we know that you will regard it as your duty to do everything you can to counteract such a legacy, whether it's in the whole of the UK or Northern Ireland in particular. And we also know that you will appreciate that this will not be achieved without the inquiry and the health and political systems concerned asking themselves searching questions. We see our role to do everything we can to assist you and your team in that task, and look forward to continuing to do that over the next 3 weeks.
Thank you very much indeed, Mr Walcott. Very grateful. Ms Mitchell.
I appear as instructed by Amar Anwar and Company on behalf of the Scottish COVID bereaved. Chair, you have already in Module 1 found that the UK was ill prepared for dealing with the catastrophic emergency of the pandemic. Our system of building preparedness for the pandemic was found to have suffered from several significant flaws, but perhaps one of the most critical failures was the lack of attention to the systems that would help test, trace and isolate infected individuals. In the event, there was no system that could have been scaled up. Planning guidance was insufficiently robust and flexible. Policy documentation was outdated, unnecessarily bureaucratic and infected with jargon. The failures to have in place the essential tools to combat the pandemic meant that the UK entered 2020 far behind where it ought to have been. My learned friend counsel to the inquiry, Miss Cartwright, KC, has outlined the issues to be examined. The Scottish COVID bereaved would like to highlight some of the matters which are of great importance to them. The failure to put in place proper processes and procedures for the testing of those being sent from hospitals to care homes and vice versa. The lack of routine testing in care homes for residents or staff. Visitors to family members not being given advice, far less being tested when visiting. Staff being moved between care homes without being tested. Residents, carers, patients and staff only being tested if they were symptomatic, with no consideration given to older people not always presenting with the so-called cardinal symptoms. The financial and practical support offered to those who are required to isolate. This is of particular importance in relation to care homes, where many underpaid staff may have felt a measure of financial compunction to attend work, even when ill. The track and trace system being inadequate and unable to keep up with the virus, it too quickly become overwhelmed in the pandemic. The inquiry will hear evidence from a member of the Scottish COVID bereaved, Nicola Boyle, as well as the bereaved from other nations. Sadly, the experiences of the Scottish COVID bereaved are all too similar. There was an abject failure of testing and tracing, and as a result, the most vulnerable amongst us suffered, and, in the case of Scottish COVID bereaved, they died. While the bereaved cannot bring their own loved ones back, they are determined that when the next pandemic comes, no one should unnecessarily suffer as they did. The Scottish COVID bereaved look forward to the evidence that will be heard by the inquiry in this module and are ready to assist the inquiry in any way they can. These are the opening submissions on behalf of the Scottish COVID bereaved.
Thank you very much indeed, Ms Mitchell. Very grateful. Next we have, is it Ms Parsons? There you are. I'll move across. There we go.
Thank you, my lady. These opening submissions are made on behalf of the COVID-19 Bereaved Families for Justice Cymru. The submissions highlight aspects of the Test, Trace and Protect programme in Wales that are of particular importance to the group. It is important to note at the outset that the programme was specific to Wales, and it diverged significantly from the programmes in other nations of the United Kingdom. And it is the experience of many of the group's members that the programme in Wales was chaotic. Policies appeared ill thought out and ineffective, messaging was confused and confusing, and implementation was late and inconsistent. The group are keen to understand why this was the case, why policies diverged as they did, and why policies were implemented late. Within the programme in Wales, the key concern relates to testing. From very early on, Wales went down its own path. First, its value was denied or overlooked. Then, when accepted, implementation was delayed. Concerns were raised in a letter from MPs on the 30th of April 2020 to the then First Minister, Mr. Mark Drakeford. They wrote this: "We write with alarm in respect to the disparity that now exists in COVID-19 testing availability between England and Wales." The letter then went on to outline the headline disparities. In Wales, availability of testing was limited to symptomatic key workers and their family members. By contrast, in England, testing was much more widely available. A crucial difference was that testing was available to all key workers and all care home residents, whether symptomatic or not. In addition, the symptoms required to get a test were also restricted. There was evidence as early as April 2020 that COVID-19 involved a broader range of symptoms than the cardinal three: fever, cough, and loss of smell. But the failure to expand the range of symptoms for testing in Wales, even when the wider symptoms were widely known, is unexplained and likely resulted in the further transmission of the virus. Turning now to some specific testing issues in care homes. The failure of the Welsh Government to provide routine testing in care homes is a priority issue for the group. Mr. Drakeford's comments on this issue are concerning. On the 29th of April 2020, he told the Senedd that routine tests were not offered in care homes because, and I quote, "the clinical evidence tells us there is no value in doing so." His own head of science, Robert Hoyle, wondered what the rationale, evidence and advice was behind Mr. Drakeford's comment. And then again on the 6th of May 2020, Mr. Drakeford told the Senedd this: he had, and I quote, "not seen any clinical evidence that led me to believe that testing of non-symptomatic residents and staff in care homes, where there is no coronavirus in circulation, had any clinical value." On the 16th of May 2020, the Welsh Government finally changed its position, almost 3 weeks after England, and introduced some routine testing in care homes. It was confined to large care homes for reasons not at all clear to those working in care homes, and only expanded to all care homes in mid-June 2020. In the context of this most vulnerable population, these delays are significant, as explained by care home owners in Wales. The owner of one care home in Newport reported how she first observed symptoms on the 20th of March 2020. She requested tests from Public Health Wales, but none were available. 3 days later, the care home had its first death. Within a few weeks, 14 residents had died. Public Health Wales had visited the care home in that period just once, testing just 3 residents. Similarly, the owner of a care home in North Wales reported how she had campaigned extensively for routine testing because of the risks of asymptomatic transmission. She knew that her residents were falling ill and dying within 48 hours of becoming symptomatic. No testing had been made available by Public Health Wales, not even for those with symptoms. The delays in testing, in particular routine testing, are unexplained. Turning to testing issues in hospitals, my lady. Testing in hospitals in Wales followed a similar pattern, with delays in the introduction of routine testing, insufficient levels of testing, and patchy implementation. This was the case both for healthcare workers and for patients. As to healthcare workers, the British Medical Association have described the wait to introduce routine healthcare testing in Wales as inordinate. It was not until the 14th of December 2020 that Wales commenced a policy of routine testing twice weekly for healthcare workers, that same policy having been introduced in England a month earlier. However, most health boards in Wales did not implement routine testing of healthcare workers until March 2021, and in one case as late as July 2021. Furthermore, Whilst the policy mandated testing twice weekly, in practice, it only took place every 5 days. As to patients, whilst the Welsh Government announced routine testing on admission in June 2020, in practice, routine testing was not done until much later on, and even then, not consistently. It was not until the 28th of January 2021 that the Welsh Government introduced repeat testing every 5 days for asymptomatic patients. However, many patients waited many more days for repeat testing in what felt like a testing lottery. One member recalls how in December 2020, her loved one was admitted to hospital with a non-COVID related issue, and his health rapidly deteriorated. However, he was not tested until his 4th day following admission. Instead, he underwent a series of intrusive and invasive tests during that period. When eventually tested for COVID, it was positive. He was discharged without a further test and later died from COVID. Teresa, who appeared in the Impact video, recalls how in February 2021, her mother was admitted to hospital for a non-COVID related matter. She was tested whilst in her ward, and the test result was negative. She was not tested again for another 10 days, despite her ward being closed due to a COVID outbreak. When eventually tested again, she was positive and died just a few days later. As the inquiry will be aware, so many of the group's members lost loved ones as a result of nosocomial infection acquired in hospital or in a care home setting. This was particularly during the second wave. By way of example, 39% of cases of COVID-19 in January 2021 in Wales were hospital-acquired. Given the availability of testing, and given the knowledge by then that testing would reduce transmission within hospitals, why was routine testing subject to such an inordinate delay? Why was testing not implemented consistently in accordance with the levels required by policy? The answer to those questions may be multifaceted. Vaughan Gething, as we heard from counsel to the inquiry this morning, said science will guide us. But the group invites the inquiry to pay careful scrutiny to the claim by the Welsh Government that their testing policies, particularly in relation to asymptomatic testing, were based on science. The questions arise. Why was that evidence and science any different to that which was available and applied elsewhere in the United Kingdom? What processes were in place in Wales to ensure that decisions were science-led? In a text message in March 2021, the Welsh Government's Chief Scientific Advisor, Dr. Rob Orford, asks a colleague this: do we need some emergency science for cabinet discussion? Whatever the precise meaning of emergency science, the casual approach to scientific advice is alarming. To adopt the question asked by counsel to the inquiry in Module 2B, was the Welsh Government's position on asymptomatic testing, and I quote, a position that could have been genuinely or sensibly held? It is a critical issue, my lady, and one which the group invites you to revisit during the course of this module. Thank you.
Thank you very much for your help, Mr. Parsons. Mr. Thomas.
Milady, before we begin to understand what went wrong with test, trace and isolate during the pandemic, we must first address the fundamental question. Inclusion. A truly effective public health response is one that serves all communities equitably. It's not enough for a system to work only for some communities. It must work for all. The ability to identify and respond to health crises hinges on how well we understand and address the needs of every individual, regardless of their background, their ethnicity, or socioeconomic status. This inquiry is not just about uncovering what went wrong, it's about ensuring that in the future, every voice is not just heard, but listened to and acted upon. When we speak of test, trace, and isolate, we're not just talking about a system that exists in a vacuum. It's a system that intersects with real lives shaped by various experiences of access, vulnerability, and trust in public institutions. For our members, FEMO, and their communities, many of whom faced entrenched inequalities in health and social outcomes, the system was not just about testing positive for a virus. For them, it was about survival in a system that too often overlooked their specific needs. So I ask, what would an effective TTI system look like for everyone? For the minority ethnic healthcare worker, worried not just about the virus, but also about the lack of culturally competent PPE, and perhaps the inability to isolate safely in overcrowded housing. For the essential worker of colour, struggling with the reality that financial support for isolation was not sufficient to cover basic needs, let alone the risk of losing one's job. For the migrant worker, excluded from mainstream systems of support due to immigration status or language barriers. You see, as we're examining the failures of the TTI system, we must ask ourselves, how do we ensure that when we respond to the next crisis, no one is left behind? How do we make sure that the voices of the most vulnerable, those who experience multiple layers of disadvantage, are not just heard, but central to the decision-making process? Inclusion is not just a matter of fairness, it's also a matter of effectiveness. A TTI system that fails to reach minority ethnic communities fails to achieve its fundamental goal, to protect public health. If this inquiry is to contribute meaningfully to public future health strategies, it must begin by embracing the principle that equity must be embedded in every decision made in the design, implementation, and communications of such systems. So while the TTI system was intended to ensure that everyone who needed to get a test could get one, this was not the experience for many of our members and those in their communities. Testing sites were often located far from areas where communities lived, creating a physical barrier to access. The lack of outreach and engagement with these communities meant that people didn't even know where to get tested or didn't trust the process enough to participate. For our members, there was a lack of clarity about availability of testing and the degrees of enforcement for non-compliance. NHS trusts differed in their approaches, leading to confusion and frustrations about how the systems worked. And even when testing was available, the system failed to account for specific needs of minority ethnic groups, inadequate translation of vital information, limited digital access, and language barriers created additional obstacles. Our members were not consulted during the design phase. As such, the system assumes that everyone had equal access to digital devices and the internet. But we know that many minority ethnic households were disproportionately impacted by digital exclusion. And this resulted in further disparities in testing rates and a lack of equitable participation. Moving beyond testing, the failure to provide adequate support and isolation was another glaring issue. For many minority ethnic healthcare workers, particularly those in low-paid, precarious employment, the financial support offered for isolation was simply insufficient. The £500 payment for isolation was inadequate for those who had to take time off work, and in many cases, it was difficult to access. Our members were also likely to be the staffers with the least access to statutory sick pay. For individuals living in overcrowded conditions, often in multi-generational households, isolation was not even a practical option. The very design of the system failed to take into account these socio-economic realities. How could individuals comply with isolation when they were already struggling to make ends meet? How could they isolate when their living conditions simply didn't allow for it? The failure to address these socio-economic factors relevant to the black ethnic minority communities not only left these communities vulnerable, but also exacerbated existing inequalities. Communities which were already at high risk of poor health outcomes found themselves not only more likely to contract COVID-19, but also more likely to suffer its effect due to inadequate support in place. The failure, milady, to design a system to take these issues into account speaks of a fundamental oversight in the planning and the execution of a TTI system. Ultimately, what we're left with is a TTI system that was not fit for purpose when it came to serving minority ethnic healthcare workers and their communities more broadly. It was not designed with inclusivity in mind, and as a result, these communities were left exposed to the worst of the pandemic. They were not just sidelined, they were excluded from a system that failed to take their needs into consideration at the outset. This is a crucial point. The inadequacies in the TTI system were not just as a result of operational oversights, they were as a result of systemic failures to address health inequalities and structural racism. One of the most glaring features we've seen throughout this inquiry is the government's failure to properly implement the public sector equality duty. The PSED is not just a tick box exercise, as I've said many times before, but it's a means by which public policies are required to serve all communities fairly. The failure to consider the impact of multi-generational households in the context of TTI, for example, resulted in all kinds of challenges for those who lived in such circumstances. Compliance with the rules about TTI could literally put entire families at risk of infection. And there is likely to be no buy-in to a set of rules that seemingly was inimical to the very existence of one's community. Let me finish by saying this. There then was a lack of disaggregated data on ethnicity and race. And even when there was data, it was often not clear whether the research was being conducted into testing, tracing, or isolation as distinctly different areas of inquiry. In matters of race and ethnicity, there was a huge reliance on anecdotal information, which was unsophisticated to say the least. Worryingly, it was not clear what channels existed for feedback from frontline or senior leaderships to the desks of policymakers. These issues were compounded by a lack of engagement with the very communities most affected. So, milady, the absence of targeted interventions and the pursuit of a one-size-fits-all approach proved ineffective and frankly exacerbated existing disparities. At its very core, milady, the failure of operational the TTI involved trust, effective public health interventions, which cannot succeed without the trust and active participation of the communities they are designed to protect. If we are to safeguard public health in a future crisis, we must prioritise community engagement at every step, ensuring that community leaders, especially those marginalised groups, are not just consulted but integral to the design, implementation of the system itself. Thank you, milady.
Thank you for your help, Mr. Thomas. Right, we'll break now. I shall return at 2:05.